Let's go on to the next set of speaker. Interesting topic on pseudophakic diabetic macular edema is going for is Dr. Preetam Samant, our very close senior colleague in the field of vitreoretina and very well known. Is from JJ, and he'll be speaking on the pseudophakic diabetic macular edema. And the first choice is intravitreal steroids, and he would be argued against by Dr. Thenasaran, another young and dynamic surgeon from the Eye Foundation, as his first choice as anti-VEGF. Over to Dr. Samant, sir, please. Preetam, sir.
Thank you, Dr. Srinivas. At the outset, my gratitude to Dr. Chitra Madam and the ARC for having me here. It's a phenomenal feeling to be in the midst of all the doyens of Indian ophthalmology. So let me kick off the talk. I'm up against a very formidable opponent, I believe, Dr. Thenasaran. And, you know, Dr. Namrata Sharma just threw a googly some time back. She said that he's a student and he's a wonderful student. So I'm wondering what he's doing with the retina topic. So, you know, when I heard that, I have prepared a googly at the end of this presentation for him. So let me start the presentation now. So pseudophakic DME. So when I debate this topic, I have to debate why I will go for steroids in pseudophakic DME, diabetic macular edema. And then the second part of my presentation is why I will not choose anti-VEGFs. So what are the treatment modalities we have for diabetic macular edema? You know, laser is not so popular now because of the collateral damage we know. So that's why we are left with the pharmacotherapy, that is anti-VEGFs and steroids. If there is DME with traction, we go for surgery. Now, corticosteroids, there's ample evidence in literature that corticosteroids are broad-spectrum anti-inflammatory agents that affect gene transcription and protein upregulation, and they do play a role in diabetic macular edema. In fact, they don't only have anti-inflammatory effect, but the effect also crosses over and has some anti-VEGF effect on the diabetic macular edema also. So essentially, they help to bring down the inflammation. They work on angiogenesis, reduce the oxidative stress, help with the apoptosis and neuroprotection. Now, this is a picture from, you know, more than 10 years back when we had only triamcinolone, and you can see how well the triamcinolone has helped in controlling the diabetic macular edema. A repeat triamcinolone again helps to this 3 months post triamcinolone. The diabetic edema does come back and you have to repeat it, but after almost 3 months. So when I debate on why steroids, I will tell you why they are, the efficacy of the steroids and the safety profile, because these two things are important when you root for one particular pharmacotherapy. And what better way to talk about the efficacy than this landmark trial, the DRCR network trial, which was, you know, one of the major guiding principles for treating diabetic macular edema. This was a trial which had a head-to-head comparison between anti-VEGF and triamcinolone versus sham treatment. Now, what they found was in the first year, you can see all of them going hand in hand, all of them going pretty well. You know, this is the steroid and these are the two anti-VEGF arms. They are going pretty well. But when you saw towards the end of the first year, the steroid arm started dipping down. The results started going down, whereas the anti-VEGFs, the vision improvement was much better. Now, mind you, this was the entire subset of patients. When you look at only the pseudophakic patients, that is this results is only in pseudophakic DME. When it was extrapolated in pseudophakic DME, you can see the steroid arm doing in fact better than one of the anti-VEGF arms and equally good as the both anti-VEGF arms. So I think we have enough evidence to say that the efficacy of steroid is there. What about the safety profile of steroid? Now, if it's a patient with systemic comorbidities, I will feel very safe to give an intravitreal steroid. If it's a pseudophakic patient, anyways, I don't have to worry about cataract. My only concern would be glaucoma. But then, you know, triamcinolone is history now. We have, fantastic armamentarium with us like this dexamethasone implant, which gives a metered dose of dexamethasone over a sustained period of time. So it is not only safe, but long acting. In fact, there are certain randomized trials, recent ones like this MEET trial of 1,000 patients, where you can see how minimally the IOP goes up. This is the baseline sham treatment, and with the dexamethasone implant in DME, the IOP is going up and coming down again. So really speaking, glaucoma is a concern, but not as much as it is made out to be. So what is the advantage here? It is long acting. More importantly, lesser visits for the patient. Remember, your diabetic patient is not only visiting you, He's going to the nephrologist, he's going to the endocrinologist, he's going to the diabetic food guy. So he has to visit so many people, and if he has to come to you every month, he's had it. More importantly, less cost. So look at your elite and the poor patient. In the elite patient, where you're going to choose Ozurdex over these two, still your cost is less. In the poor patient, your triamcinolone, which is 70-80 rupees, is still lesser than the aliquot of bevacizumab that you're going to use. So it is a winner definitely all the way. This is one of my recent patients. You can see the diabetic macular edema, the FFA, the OCT, and with 2 implants over a period of 9 months and some rescue laser, you can see how the diabetic macular edema is come under control. Now the last part, why will I not prefer anti-VEGFs in some of these cases is again repeated dosing. So repeated visits, uncontrolled diabetics bind you multiple infections, multiple chance of infection and endophthalmitis. That also has to be taken into account. The cost factor is large, and diabetics, there is always insurance woes. The insurance company is always saying no to diabetics. Mind you, take that into account. And if there are comorbidities like ischemic heart disease, cerebrovascular comorbidities, then you have to bear caution with anti-VEGFs. Remember, one of the major trials, that is Protocol T, although they did not find a significant adverse events in some of these anti-VEGFs, if you look at the fine print, a greater number of non-fatal strokes and vascular deaths did occur in the ranibizumab group, although not statistically significant. And there is enough evidence in literature where they have studied pharmacokinetics and shown that these anti-VEGFs actually reduce the normal plasma free VEGF levels. So that can cause a higher chance of a cerebrovascular accident. So this is my concluding slide, that when you're making decision in pseudophakic DME, in any DME, you have to take the lens status into account. If it's a pseudophakic patient, then I will definitely go towards steroids. But look at my algorithm. If it is a focal non-center DME, then laser will still be the gold standard. If it is a diffuse center involving DME in a phakic patient, I would probably go towards anti-VEGF. But if it's a pseudophakic patient and who's not a steroid responder, I'm not worried about glaucoma, I will choose steroid. Now for the googly. Now what happens if we combine steroid with anti-VEGF? So this is a question for my dear opponent when he talks. Thank you again.
Thank you, Preetam sir. You made your points very well.